morning everyone. Hi and welcome to all 4 C learning classes session 5. The mechanism of the breathing which involves inspiration and expiration. Diagrammatic explanation now we'll see. Look at the 2 diagrams we have seen which includes we have discussed that the lungs present in the thoracic cavity are of what is said to be the airtight chamber. What do you mean by that? That is, what we learn is the lungs are bounded by dorsally vertebral column, ventrally by sternum, and the lower side it is by diaphragm and laterally by ribs. So the lungs present in the thoracic cavity are airtight chambers such that lungs cannot bring about changes in the exchange of gases or the breathing mechanism. It is by the change in the thoracic cavity what bring about the changes, that is exchange of gases and the mechanism of the breathing. In this connection now we'll see how the changes in the thoracic cavity will influence the inspiration and expiration. Mechanism of the breathing involve the inspiration, expiration. The intake of the pure air, the intake of air into the lungs is what named to be the inspiration, and the elimination of the foul air to the outside is expiration. So the change in the thoracic volume would bring about the change in the lungs. The principal respiratory muscles are the muscles that assist in respiration. If we see, we have already discussed that includes the intercostal muscles, to the phrenic muscles, and 3 is the abdominal muscles. Let me clear you this. Intercostal muscles in the sense the muscles that are associated with the ribs. Costa refer to the ribs. The intercostal muscles what surrounds the ribs, which includes the external intercostal and internal intercostal. That is, one that is what outside and one that is inside. External intercostal and internal intercostal muscles are what the 2 types of the muscles associated with the ribs, what name it to be the intercostal muscles. And the phrenic muscles in the sense the muscles associated with the diaphragm, or also name it to be the radial muscles, and the muscles that is oblique muscles of the abdominal region is abdominal muscles. Generally the intercostal muscles, phrenic muscles, we have seen that in order to take in air inside, the thoracic volume is to be increased so that the lungs volume increase. The increasing in the volume decreases the pressure. Always the gas is diffused from the concentration of the high to low. I already emphasized, I have given you information that the atmospheric partial pressure of oxygen is 150 to 159 mmHg. 159 mmHg. This is atmospheric partial pressure of oxygen, PO2. The denotation of the oxygen is the partial pressure of oxygen, PO2, PCO2 is carbon dioxide. So always gases move from partial pressure of high to partial pressure of low. Atmospheric oxygen partial pressure is 159 mmHg. At alveoli of lungs, the partial pressure is 104 mmHg. at alveoli of lungs. Next, the oxygenated blood carrying blood capillaries are with 95 mmHg. The blood vessels that carry the oxygenated blood, systemic artery and pulmonary vein. We know very well arteries are carrying the blood from heart to different parts. In this connection, the arteries carry the oxygenated blood to the tissues. So, the partial pressure of the oxygen in the pure blood, that is the oxygenated blood we say, where the 95 mmHg, at tissues it is 40 mmHg. Is it in a descending order or not? Yes. What I mean to say, from higher concentration to lower concentration. At tissues the 40 mmHg is the partial pressure. What did I say? Gases drift from higher concentration to lower concentration. So in this connection, atmospheric air with the partial pressure of oxygen 159 to alveoli of lungs 104 mmHg, then to the oxygenated blood carrying the systemic arteries, oxygenated blood with 95 mmHg, and reaches the tissues as there is a low partial pressure of oxygen. The exchange of gases takes place as at tissues the oxygen partial pressure is low partial pressure in the sense the demand is more. So the oxygen is supplied to the tissues. That is what inspiration. And expiration, sending out air outside. Now inspiration, what I say, that the three types of the muscles, intercostal muscles, phrenic muscles, abdominal muscles, play a role in respiration. Always the gases drift from higher partial pressure to lower partial pressure. The partial pressure in the lungs is named to be the inside the lung intrapulmonary pressure. As oxygen partial pressure 159 mmHg at the lungs, relatively, comparatively in the lungs it is less. 159 and 104. Is it less or not? Yes. In lungs, the partial pressure of oxygen is 104. So, the negative intrapulmonary pressure means less when compared with the atmospheric. So, the negative intrapulmonary pressure what allow the oxygenated air, atmospheric air diffuse into the lungs and thereby to different parts. So, here this negative intrapulmonary pressure is what taking air into the lungs, and negative less, how the less pressure generated in the lungs, that is in the thoracic volume, which means the muscles called intercostal muscles, inspiration, intake of oxygen containing air, where the thoracic volume need to be increased. The increase in the volume decreases the pressure. So, the first external intercostal muscles contract. The contraction of external intercostal muscles causes the increasing in thoracic volume dorsoventrally, external intercostal muscles contraction. At the same time, the contraction of diaphragm. In the beginning we discussed that rib cage and diaphragm play a role in respiration in mammals. So, the contraction of radial muscles of the diaphragm or phrenic refers to the diaphragm. The contraction of the phrenic muscles causes the dome-shaped diaphragm what become flattened. Diagrammatically you can see, enlarge karo. Diagrammatically you can see that the volume of the thoracic volume here increased, here decreased. So the diaphragm, due to contraction of diaphragm muscles, the diaphragm of dome shaped become what is called flattened. Flattened in the sense, diagrammatically look at here, this is dome shaped. Now this dome shaped become flattened. So do you find the gap of this is increased or not? Volume is increased or not? Definitely. Look at the volume you find here is more. Why? Because of the contraction of external intercostal muscles. The ribs and the sternum lifted up and moved forward, and so the volume in dorsoventral increased. At the same time, the diaphragm, the contraction of the phrenic muscles causes the lowering of the diaphragm or flattening. Look at here, this is convex. Now here it become the flattened. So this area is increased or not? Yes, definitely. So the volume in anterior-posterior axis and dorsoventrally increased. Increased volume decreases the pressure. This causes the drifting of oxygenated air into the thoracic volume, then into the lungs. Thoracic volume in the sense the lungs. So that's what inspiration, and later the events what takes place, that is diffusion of gases, transport of gases, or else the exchange of gases or diffusion, both are same at the lungs and the blood and lungs, then transport, then between the blood and tissues and the tissues blood, vice versa. So what we come to know at the end, the contraction of intercostal muscles and contraction of phrenic muscles, the thoracic volume increase as it is the contraction of the muscles. So the inspiration is said to be the active process. Next, the expiration. Expiration is sending out foul air to the outside. Diagrammatic views, what you are observing is the thoracic volume is decreased, the lung volume is decreased. Decreasing the thoracic volume decreases the lung volume. How? The relaxation of the external intercostal muscles. The ribs and sternum regain their original position, come to their original position. Relaxation of the diaphragm muscles or the phrenic causes the diaphragm upward and arched. Look at here, arching, or else become dome shaped or convex. Regaining of the sternum and ribs original position, come to their original position, and diaphragm moved arched upward. That is, it becomes the dome shaped. So lung volume decreases. Decreasing in the volume increases the partial pressure. So intrapulmonary pressure for foul air is more in the lungs when compared with the carbon dioxide in the atmosphere. So carbon dioxide containing air, foul air, is what sent out. This is expiration. So the changes we find in expiration, sternum and ribs come to their original position, and ribs diaphragm is arched upward. Thoracic volume, thereby lung volume decrease. So intrapulmonary pressure increases for foul air, that is carbon dioxide, and carbon dioxide is sent out. This is what we see the inspiration and expiration diagrammatic view. And here also you can see a diagram which shows the movements during the breathing. What do you find? The dotted lines you see and the straight lines you see. In a dotted lines, the volume is less, whereas straight lines, the what is called volume increases. So this indicates the narrower the volume, the higher the pressure. So air is sent out, that is expiration. And the straightened lines indicates the what is called it moved, increased in volume. So pressure decreases, so air enters. This is entirely the mechanism of the breathing. Now let's see. These breathing are brought about by the movements. These breathing movements. Generally, the breathing movements are 12 to 16 times in a human beings. Breathing is 12 to 16 times. But when you sleep, it is we find the changes, and even the children are with what is called more number of the breathing rates. Even children are also with the more heartbeat. The due reason is they are with the more activities. In terms of the heartbeat, I am saying. Children are, if you keep the hand here, you will sensitize that the increasing in the number of the heartbeats as their activity is more. So the number of respiratory beats per minute are 12 to 16 times. This is what we do discuss in the case of the number of the beats per minute. And apart from that, the breathing can be broadly, if we go to the discussion, we see the thoracic breathing, lateral thoracic breathing, and abdominal breathing. In the case of the men and women, in the case of the men, make a note, this is an additional information we see. In the case of male human beings, 75% of the breathing is by abdominal breathing, whereas 25% is the thoracic breathing. I repeat, what we learn is in men, 75% of breathing is by 75% of the breathing is by abdominal, and 25% is by thoracic breathing, lateral thoracic breathing. Whereas the case with the pregnant woman and the woman, it is predominantly lateral thoracic breathing. I repeat, in men and women, the breathing movements are, in the case of the men, 75% of the breathing is abdominal breathing, 25% is of the thoracic lateral breathing or movement. Whereas the case with the pregnant woman and woman, it is a predominantly lateral thoracic movement. Next, let's see the case with the mammals. Among the mammal, it is named to be the negative pressure breathing. The due reason is, we see among the mammals, the palate is a structure which is responsible for chew and breathe simultaneously. Chewing and breathing what takes place by means of what is called the palate. So here we see it is a negative pressure breathing. And some more point to discuss in this connection, that is the advantages of breathing by nose. Even we came across the people breathing with the mouth also, which is not good sign of the health. That is, this happens with when the nozzle blockage takes place, the breathing what also partially takes place with the nozzle tract, nozzle passage, and also by oral passage. So the advantage of the nozzle breathing is, it is absolutely an advantage. Why? While nozzle breathing, the dust particles are what trapped by hair. Next, mucus also trap the what is called bacteria, and air conditioning is taking place. These are all the advantages of the nasal breathing. Now it is the topic to be discussed is pulmonary volumes and pulmonary capacities. Respiratory volumes and respiratory capacities. Right. Pulmonary volumes in the sense or respiratory volumes in the sense the volume of air that is inhaled, the volume of air that is inhaled, hold and expelled is what named to be the volume, pulmonary volume or respiratory volume. I repeat, pulmonary volume or respiratory volume in the sense the volume of air, the air that is inspired or taken in, the air that is received, the air that is hold and the air that is expelled is what named to be the pulmonary volume or else the respiratory volume. And combination of the pulmonary volumes, the combination of one or two or more, the combination of two or more pulmonary volumes or respiratory volumes, we say is a pulmonary capacity or respiratory capacities. Now we'll continue to discuss how these pulmonary volumes and pulmonary capacities what taking place. And now the details why we are discussing. So far we have seen how the mechanism of the breathing occurs. Here the pulmonary capacities are of the clinical diagnosis purpose. In order to diagnose a person the defects in the lungs, the pulmonary capacities are of important. This is the reason why we see the pulmonary capacities. I repeat, pulmonary volume or respiratory volume in the sense pulmonary volumes or respiratory volumes in the sense the air that is received, the air that is held and the air that is expelled is pulmonary volume or respiratory volume. Whereas the pulmonary capacities in the sense pulmonary capacities are the respiratory capacities in the sense the two or more pulmonary volumes together said to be the pulmonary capacities or respiratory capacities. They are of for clinical purposes. Now we'll discuss the pulmonary volumes first, that is the tidal volume. TV refers to tidal volume. Particularly pulmonary volumes and pulmonary capacities are paramount important for NEET purpose. Yes, you can see and be evident that for the last few years, not one or two, right from the beginning, a question is definite from the pulmonary volumes and pulmonary capacities, either in the match the following or else in a definition or else volumes or else ascending or descending order of these volumes. Definitions, volumes, equations, match the following type of question. The volumes ascending descending order is compulsory. So dear students, keep in mind that these volumes need to be memorized. Yes, definitely. All the definitions need to be memorized. You have to by heart. Why? Means there is no what is called application. It is definition one. So look at here, tidal volume. Tidal volume in the sense the volume of air that is breathed in or breathed out. The volume of air that is breathed in or breathed out per a beat is what named to be the tidal volume during breathing. The volume of air that is either breathed in or breathed out during respiration is what named to be the tidal volume. Tidal volume per one beat. Per one beat it is 500 ml. 500 ml. 500 ml. It is considered to be, of all the volumes, the lowest volume is none other than the tidal volume itself. So, what is the tidal volume of human being per a minute? How do you calculate? Come on, answer. That is, we have discussed that in human beings per a minute the number of beats are 12 to 16 times. Is it right? Yes, the number of the respiratory beats per a minute are 12 to 16 times. So, the per a beat, how much amount of the air is breathed in or out during respiration? 500 ml. Now, answer, what is the tidal volume of human being per a minute? What answer you give? Definitely it is 6,000 to 8,000 ml. How? That is 500 ml into 12. Why? Per a minute the number of beats are 12. 12 into 500. 12 5s are 60. 6,000 ml. 6,000 ml of the air which is either breathe in or breathe out during respiration is a tidal volume, or else the 16 times. So 16 into 500, 16 5s are 80, so 8,000. So it is 8,000 ml. So either 6,000 to 8,000 ml is the tidal volume per minute. Be careful. You are given both the volume in the textbook, but not given why it is 6,000 to 8,000. Let's see, the second one is inspiratory reserve volume. IRV refers to inspiratory reserve volume. The volume of air that is forcibly inspired is what name it to be. The volume of air that is forcibly inspired is what name it to be the inspiratory reserve volume. The volume of air that is forcibly inspired is what name it to be the inspiratory reserve volume. Basically it is also named to be the forced inspiration, which is the 2,500 ml to what is called 3,000 ml. Next, the expiratory reserve volume, the volume of air that is what is called expired forcibly. Here the volume of air inspired forcibly is a inspiratory reserve volume, which is 2,500 ml to 3,000 ml. The volume of air that is expired forcibly is what named to be the expiratory reserve volume. And this expiratory reserve volume is expiratory reserve volume. Reserve volume is none other than the expiratory reserve volume. What? 1,000 to 1,100 ml. 1,000 to 1,100 ml. Next, reserve volume. The volume of the air that remain in the lungs after the forcible expiration is what name it to be the reserved volume. Reserved volume. The volume of air that remains in the lungs. The volume of air that remain in the lungs after forcible expiration is what name it to be the reserved volume, which is 1,100 ml to 1,200 ml. So all these volume what we discussed is a pulmonary volume. Pulmonary volume in the sense the air that is received, the air that is received, hold and expelled, which includes tidal volume TV, inspiratory reserve volume IRV, expiratory reserve volume ERV, reserve volume, reserved volume. The volumes are 500 ml is the tidal volume per a beat. So per minute what we see is 500 into 12 or 500 into 16. So that's what 6000 to 8000 ml. And inspiratory reserve volume, the volume of air that is inspired forcibly or forcible inspiration is what named to be the inspiratory reserve volume, which is 2005 ml to 3000 ml. Expiratory reserve volume, the volume of air which is expired forcibly is what named to be the expired reserve volume, which is the 1000 to 1100 ml. Reserve volume, the volume of air that remain in the lungs after forcible expiration is what named to be the reserved volume, is what named to be the reserved volume, which is 1100 to 1200 ml. These are all what pulmonary volumes. Two or more pulmonary volumes or respiratory volume when combined results in pulmonary capacities. The pulmonary capacities or the respiratory capacities in the sense the two or more pulmonary volumes or respiratory volume when combined together what results in pulmonary capacities. Pulmonary capacities are of important in clinical diagnosis. Now we'll see the pulmonary capacities, that is inspiratory capacity, expiratory capacity, forced functional residual capacity, vital capacity, total lung capacity. So certain times what you have to see is a residue in the sense residual in the sense what it is remained. Here the RV we have seen residual volume, residual volume, residual volume RV. Residue means that is remained. That's what we need to be learned. So residual volume, it is not reserve. Reserve volume is what we discuss here, but it is RV refers to residual volume, what remain in the lungs. Residue refers to what is stored, remain. Inspiratory capacity, inspiratory capacity, inspiratory capacity. Inspiratory capacity in the sense the volume of air inspired after a normal expiration is what named to be the inspiratory capacity. The volume of air, inspiratory capacity, capacities, these are all what we are discussing. Inspiratory capacity in the sense the volume of air that is inspired after the normal expiration is what named to be the inspiratory capacity. Next, the expiratory capacity. Expiratory capacity in the sense it is the volume of EC, expiratory capacity. Expiratory capacity in the sense the volume of air that is expired after the normal inspiration is what named to be the expiratory capacity. These are capacities. And the what is called FRC, functional residual capacity, functional residual capacity. functional residual capacity in the sense the volume of air that remain in the lungs after normal expiration. The volume of air that remains in the lungs after normal expiration, we say it is a functional residual capacity, which is FRC. FRC. Vital capacity. Vital capacity can be denoted as VC. The volume of air which is the volume of air that is breathed in after forcible expiration is a vital capacity, or else the volume of air which is breathed out after forcible inspiration is what named to be the vital capacity. I repeat, vital capacity in the sense the volume of air which is breathed in after forcible expiration is a vital capacity. It can be both the way we can say. The volume of air which is breathed out after forcible inspiration is what named to be the vital capacity, VC. Next, total lung capacity. The volume of air that remains in the lungs, after forcible inspiration is what we name it as a total lung capacity. Total lung capacity. In the sense, the volume of air that remain in the lungs after the forcible inspiration is what named to be the total lung capacity. So these are what we see as volumes as well as the capacities. I repeat, tidal volume. Tidal volume in the sense which is denoted as a TV. The volume of air that is breathed in or breathed out during normal breathing is named to be the tidal volume, which is 500 ml per beat, and the per minute, if we taken into consideration, per minute it is 500 into 12 or 500 into 16. Why? The number of beats per minute are 12 to 16 times. So 12 into 500 is equal to 6000 ml, or also 16 into 500 ml it is 8000 ml. This is what the tidal volume. Tidal volume can be the lowest volume of all the types. Of all the pulmonary volumes, it is the lowest one. Next, inspiratory reserve volume. Inspiratory reserve volume in the sense the volume of air, that is the volume of air inspired forcibly. The volume of air which is inspired forcibly, it is also named to be the forcible inspiration, or else inspiratory reserve volume, which is 2500 ml to 3000 ml. Next, ERV, expiratory reserve volume, the volume of air that a person can breathe in, that is expiratory reserve volume, the volume of air that is forcibly expired is what named to be the expiratory reserve volume. Reserved, it is ERV, which is 1000 to 1100 ml. And the residual volume is the volume of air that remains in the lungs. The volume of air that remain in the lungs after the forcible expiration can be said to be the residual volume, which is 1100 to 1200 ml. And the capacities, inspiratory capacity, expiratory capacity, functional residual capacity, vital capacity, total lung capacity. The IC refers to inspiratory capacity. That is, here we learn the inspiratory capacity, the volume of air that a person can inspire or inhale after the normal expiration is a inspiratory capacity. And expiratory capacity, the volume of air that a person can expire after the normal inspiration is a expiratory capacity. Functional residual capacity, the volume of air that is remain in the lungs after the normal expiration is functional residual capacity, FRC. Vital capacity can be termed to be vital capacity, that is the volume of air a person can breathe in after the forcible expiration, or the volume of air that a person can breathe out after forcible inspiration is what named to be the vital capacity, and which can be denoted as VC. TLC, total lung capacity, the volume of air that remains in the lungs after forcible inspiration is what named to be the total lung capacity, TLC.